Charter Unity Health Point in Madison. She has extensive experience in perinatal health leadership. Lisa Locken is a clinical nurse specialist at Wheaton Franciscan Healthcare St. Joseph in Milwaukee. In addition to co-chairing the WAPC Perinatal Data Committee, she is an actual user of peridata.net and has experience using it for quality improvement. Bonnie Tudeberg is the Director of Women's Health at St. Vincent Hospital in Green Bay. She has extensive experience in hospital-based care and has worked in the larger Green Bay community to improve care in this setting. As way of disclosure, in order to receive continuing education credit, registrants must attend the full session and complete the evaluation, which will be emailed to them after the presentation. None of the speakers have conflicts of interest to disclose, and there is no commercial support or sponsorship for this presentation. Before we begin, you, the audience members, will be in listen-only mode unless you raise your hand. Note the hand icon in the upper right corner of your screen. We encourage you to ask your questions by speaking directly to the presenter using your phone or computer microphone. Also, if the presenter chooses to ask questions of the audience during the presentation, please raise your hand if you would like to answer the question. You can also ask or answer questions by typing them in the question field. I will communicate the questions or answers to the presenters in the order received. If you do not see the question pane, expand your screen by clicking the orange arrow in the upper right-hand corner of your screen. If we do not get to your questions due to time constraints, WAPC staff and the speakers will respond via email following the session. If you have any questions following the session, email them to wapc@perinatalweb.org. For technical problems, please contact Barb Wienholtz directly. There are 3 objectives for today's presentation. At the conclusion of the session, participants will be able to identify at least one example each of how data retrieved from peridata.net can be leveraged for hospital or system improvement and for community improvement. Second objective, describe at least 2 ways in which data retrieved from peridata.net can be used on its own or in conjunction with other data sources for quality and outcome improvement. And finally, name at least one example of how participants will be able to use data retrieved from peridata.net for quality improvement within their own setting. And with that, I turn it over to the speakers.
Hi, this is Lisa Locken. I'll be going first and talking about some of the everyday internal data. It's not a lot of slides. In fact, it's 1 slide, so I'm mostly just going to talk about some of the various uses for the data that we do have. Clearly, one of the main uses is standard reports. A lot of times this is just counts or percentages of information that is put together in a way that no matter where we are in the state, if we were to run that information, we would get the results that were there for each hospital, and it would all look the same, as opposed to if you had created something all on your own, we each might come up with something a little bit different. Standard reports can be very helpful. Again, they're utilized consistently around the state. So oftentimes people use these for things like going to your departmental meetings and providing information as to quality that way. Another hugely important thing, and hopefully maybe even done prior to some of your standard counts, are what I call patient-level reports. One of the things that is very important to do, and if you're not doing it now, I would suggest that you work on making that happen a lot more frequently, is what I would call truing up data from a variety of sources. Peridata.net is one type of data source amongst many. There's coding and billing information and a number of other things. And certainly errors in data entry can occur in any number of places. We can have a few entry errors in the peridata.net side. I've certainly seen coding and billing problems come through on the other side, and this is an opportunity to make sure that your information matches up one side to the other. Also, a lot of people will run things that get at, does something completely not make sense? Maybe you've got a report that says a baby weighed 500 grams, but that it was 19 weeks or something, where that clearly does not fit. So those types of things you would want to true up. As it says, they're useful prior to reporting out publicly. We do have a variety of public reporting measures, both in the PDN system and then other places that you look for this as well. And what you definitely want to do is make sure that what numbers you're sending out to somebody else are in fact correct. Again, one example might be for early elective deliveries. I know when I go in and look for that, I am looking to see does something that got coded as an induction of labor, does that match up to what we have elsewhere? And I have found an equal number of things that might be coding issues as well as anything else. So making sure that you are truing up your information is very, very important. Another thing for everyday internal data is provider pay for performance. That's becoming a much bigger issue, and I know within our organization our physicians are beginning to look for that as incentivizing for how well that they're doing. They may get a bonus if, for example, they don't have any early elective deliveries in the course of the year, or whatever kind of stats may be attached to their performance that their colleagues have set the bar for. So those types of things are easy to run in the system. Also, many, many times for internal data, we can answer specific quality questions that we may have. As one example, recently we were asked to start looking at some chorioamnionitis. Start showing which patients have that, and now we're trying to go into some of those charts to take a look at, did we in fact give the baby the antibiotics as soon as we should have after birth for any woman who had chorio? And then that's brought back issues around, well, okay, are we communicating that properly? Do we identify patients properly so that the nursery can be involved? Another thing that's not on here, which is it's somewhat internal and somewhat can and will be used for other things later, is in Wisconsin, we're still kind of in its infancy as the Wisconsin Perinatal Quality Collaborative. And what we're trying to do there is gather information that will help us make improvements around the state. But there will be pieces to that where we can look internally to see how do we compare with others, where do we seem to have issues that we need to be addressing from a quality standpoint, and so forth. So hopefully this gives you a broad overview of some of the things that we can use for everyday internal data. Say that 3 times fast. That being said, we'd like to also then discuss with you both some community improvement things where we take a totally different take on the use of peridata.net, and then after that, some real specific uses for big quality efforts going on. So first we'll talk about the community improvement, and at this time I'll turn the microphone over to Bonnie Tudeberg, and she's going to talk to you about the community improvement program that she's been involved with. Bonnie?
Thanks, Lisa. This is Bonnie Tudeberg, and I've been working with Peridata in a community program for several years. So the question was posed many years ago, what if we took some private and public entities, we came together and we used some data that we knew was being collected to make a community improvement, especially around maternal-child health. And we knew that Peridata contains lots of data that organizations outside of the hospital setting would have some interest in. For instance, how many women have access to prenatal care? How many children are born at a home that has some risk factors? How many women are delivering teen births? How many women maybe have low income and other multiple factors like maybe some narcotic substance abuse, no support system in place, etc. So those are elements that we collect, put in PERI-data, and use for lots of programs inside our hospitals. But what if we partnered together with other organizations interested in the same healthy outcomes, and we work together to see what else could be done about it as a partnership? So with that, next slide please, we developed in our community in Brown County, Community Partnership for Children. It is a prevention-focused early childhood initiative. So we bring together partners, public and private, and its vision is that all Brown County children will be safe, healthy, and ready for kindergarten. We focused on that particular age group, thinking that the school system would pick up and the elements and programs inside the school system would then take over. But the partnership is housed with the United Way and their action impact plans. So you can see already how large it can become as far as Brown County goes. All of the hospitals are involved. There's private businesses involved, along with agencies that have interest in outcomes in the community. Next slide, please. So we identify families as early as possible. Prenatally is best because you can develop rapport with the families. So we identify family needs in the prenatal period. Typically that'll be through WIC, but we also have the OB offices doing the similar screen that we would use in the hospital. And then those families who are noted to be at risk for the areas that we have most concern are reported to the program, to Community Partnership for Children. Also, and when I say reported, I mean they go on a list for a visit to be enrolled in the program. At the hospital, all women who deliver, who live in Brown County, get a welcome baby visit. And we do that by going into the patient room and welcoming them. If they scored higher on the risk assessment tool, there will be a little bit more interview done as far as being eligible to enroll in programs. If not, it's a welcome to Brown County. Here's some community resources that you might find beneficial. We encourage all agency collaboration so that the CPC, or Community Partnership for Children, becomes the gateway for who is referred to which program. It's a prevention-based system so that we aren't trying to pick up the pieces when people are already in need, but rather we want the community to support this program so we can prevent problems by using the resources already present and not overwhelming one resource, but spread it out and focusing on those areas that we picked up in PERI-data as most at risk. Next slide, please. So PCP includes the welcome baby visits that I spoke of, but then when we do identify families at risk, we do in-home visits. Again, it is not to be the place of other programs in the city because we all come together and agree who's going to do what. So that doesn't mean that, let's say, the public health doesn't do home visits, or we both are overlapping care. We decide who's going to be doing what. So again, it's not an overlap of services, but an adjunct to each other. There are parent education classes. We have structured play groups, and those are done often through resource centers and community centers. Coordinated referrals to all of the spectrum of the resources. And again, it sounds very community-based, which it is, but some of the information at the inception of our program is collected through PERI-data and reported to this program, and I'll explain that a little bit more in detail in a minute. But again, it's the hospitals coming together. So I always say, can you imagine hospitals who typically compete for business are all at the table, all collaborating, all working together with the community agencies to make sure that the families having newborns are having the best start possible to raise their children, preempt any problems that may be identified, so we can hand them off to the school system, and hopefully those children are ready to begin learning. Next slide, please. So what kind of data could we possibly collect out of PERI-data that could even remotely relate to this type of a community initiative? Well, we've decided there are 25 elements inside the report that we use. there was a screening tool that was a hand-collected data tool that was used as we assessed every woman's need for participation in the program. I have a bias to use Perry data whenever possible, and so I tried to get it as far away from a hand-collected data form. So we identified the questions inside of Perry data that most matched the paper form, and this is what we came up with. I believe if we do the next slide, we'll see a sample. Okay, so how can a community organization use the data? Okay, or like I said, from competing hospitals. So even though we may not be related to each other in our hospital systems in Green Bay, we've all decided to use the exact same report that was customized to bring up the 25 data elements that we wanted to collect. Each month we download the report, the data is populated for that past month. We de-identify it. There will be 0 names attached to this report. We send it off to the collator, who is working through Family Services in Brown County. She then combines the report and does a 6-month and an annual report that, again, is meant to help the greater good. There's information on ethnicity and age and employment, the educational level of the parents, the tobacco use in the home. I think you recognize some of these questions that are being asked in Perry data. And again, it's helped us to focus our needs. So the very first time we collected data, we thought, oh, we're probably going to have to focus on teenage pregnancy. And we turned out, no, that wasn't our greatest need. There was something else that was much more important to focus on. So the custom report in our first version of Perry data was done through custom reports, collect the questions, save it, and every month just renew the dates to get the most current information. Now that we're in Pentaho, the custom report has to be remade. We haven't quite done that yet, but it can be done, especially as we learn how to do our pivot tables. So all the questions are still there, still available, and we'll be tweaking our report to use the new Pentaho. Next page, please. So how effective is it that we would work together as a system, use this data, which leads to a bigger program where families are visited and families are followed through the resource center, etc. Well, there were hundreds of high-risk children and their families that are being served via the Community Partnership for Children and all of the gateway services that came from that. And this last year, 99% of those enrolled had no reports of child abuse or neglect. 98% of the families enrolled were linked to a primary care provider for the child or the children, and 93% showed a social and emotional readiness for kindergarten based on standardized testing in the kindergarten area. So we feel very proud that we started off a program using Perry data. We still send our Perry data information for annual reporting, and we have much more data that we use now since the program is up and running, but it is still an adjunct part. Next slide, please. So so there was a slide here, I don't think it showed. It was a picture of all the data elements, the 25 questions across the top of a table and populated down with yes, no's, and what the answers are that we would have entered into Perry data. But it was a visual of how much information you can gather, and once you build the report, it's there. And you can reuse it, and then off it goes to somebody who collates the data and presents a report showing trends over the years on the type of patients we serve and how that can be used in the community for a greater good. So from here, we will turn it over to Kathy Cascrivas, and she's going to focus on quality and use of Perry data.
Thank you, Bonnie. I'm going to go over a little bit about the roadmap that Meritor followed from an inpatient perspective and how the OB unit might take some quality initiatives and how to move them forward with the entire team to improve quality. So to speak, after you get all the data, what do you do with it? So I'm going to go through how we identified our trends and patterns, our benchmarking, how we identified our gaps in best practice, what we did with the stakeholders, how we developed a plan of action, and the process that we have been using to hold the team accountable to improvements in practice. You can move to the next slide. At Meritor, we have a women's health steering, which really drives a lot of our process improvement work for both women's OB care and newborn care. And so we had a bunch of data that a handful of providers really were aware of. So we have a nursery committee, we have a steering committee, and everybody gets all sorts of data. And that data was being presented on a regular basis to the teams, but nothing was really happening to improve practice. And so we pulled together, we got a group of our nursing leadership, and we pulled together all of our data that we thought, you know what, we really need to get a better way for everybody to first have an awareness, and then secondly to do something about it. So we pulled from Perry data, we pulled provider reports where each physician could see their delivery numbers, cesarean rates, things like that. We are part of the National Perinatal Information System database, so we pulled all of our data from there, which did a lot to help us benchmark with other perinatal centers. We pulled our patient satisfaction, and this isn't stuff we, never did before. This is just an ongoing thing, but we thought we'd make this big composite of information and put a huge presentation together. As we have a level 3 NICU, we put together our Vermont Oxford data, and then we pulled medical records using Perry data on some of these, types of measures, and we did a medical record drill down so we could pull all the medical records of a certain number of patients that had hypertension or were readmissions, for example. We went through all the medical records with a group of nursing leaders so we could identify our trends and patterns. Go to the next slide. Then, as you all know, medical team really never wants to believe anything that is true with your organization, so we really had to validate all of the work, all of the data first of all, and then we did, when the nurse leadership team did a drill down, they actually looked more detailed into the medical records. So if we, for example, we found that we had a very high rate of hypertension, readmissions at our hospital, we wanted to kind of drill down what are some of the reasons why patients came back. So that team kind of put that data together so that the medical team really had more information than just data. And then we did the benchmarking piece of it, so looked at checkpoint averages for data that was publicly reported. We looked at, the NPIC, regional perinatal center comparisons. We looked at baby-friendly, the WHO data for our breastfeeding rates and measures that we had to meet for being baby-friendly. We looked at Healthy People 2020. We looked at the Vermont Oxford data. Anywhere we could find a benchmark that says this is where you need to be, we felt we would find a lot more validity, or they would see much more validity in trying to meet the measures if there was something that was actually a goal or a target. Go to the next slide. So the next step was really to take where we are today and how we were going to get to the future state. And so we had many content experts, including OBs, pediatricians, maternal fetal medicine, doing literature searches, and we looked at resources that were available through the California Collaborative, through WAPC, the IHI, A1, ACOG, in the American Academy of Pediatrics. We looked at every guideline, all sorts of best practice articles, still a lot of literature, and identified some key strategies or ways to improve practice on several of our key measures that we found we were falling out of compliance or meeting the benchmark. And the 4 identified practice areas of opportunity for Meritor were looking at our hypertension rates, that were readmitted, our overall readmission rate. We also noted that we had adverse events for newborns was higher than the national average based on an NPIC database number, and then our postpartum hemorrhage rate. So we decided that we'd gather all the best practice around those measures in particular so that when we came to come together with a bigger group, we could really focus on how to improve those areas. So what we decided to do was what we we call the Perinatal Summit, and we've had a couple of these now. And we make it a 4-hour event, and we invite all pediatricians, all neonatologists, all OBs, midwives, family medicine, anesthesia, anybody that's related to perinatal care. And we decided that this group, we can go to the next slide, this group would be involved with hearing the information so that we could spread the quality data to everyone, and not just the handful of people that show up to a committee meeting. So we had a team that did preparation. We had information packets that included evidence-based practice. Each packet had stuff about the hypertension readmission, all of those measures that we found we were falling out from. We had key stakeholders that were table leaders there were 2 people. There was a clinical nurse specialist or a nurse along with a medical provider. Most of them were maternal fetal medicines or neonatologists for the table discussions, and they were to lead the table discussions on the day of the seminar. So we had to prepare them, and then we put all the data into a presentation that included best practice, areas of opportunity, and kind of a whole big presentation of graphs and charts that showed where we are and where we're falling short or where we are exceeding expectations. We move to the next slide. So the agenda was, we first of all did this massive presentation, and then we had the WHA came and did a pay-per-performance measure presentation to all of the providers. And it was really, the real intent for that was to get them to see what's in it for me. We really felt that if the physicians didn't realize that pay-per-performance is just coming their way and that more and more measures are really going to impact their bottom line and the hospital's bottom line, and that all of this is going to be publicly reported at some point or another, that they wouldn't see any value in it. And so we really wanted to make sure that they could see the future moving forward with that. So that really was impactful for them. And then each participant was to attend 2 table discussions. And we had designed several questions for discussion at the tables. And the intent was that based on the discussion and with the content experts there, that they would just come up with some best practices that they felt that we at Meritor could implement based on the data that they reviewed. And so each of the table discussions were to make up a recommendation for quality improvement. And then after, at the last hour of the agenda, each of the tables reported out their improvement plans, and we put them all on Post-it notes and had a board where everybody would put up their recommendations, and then we did nominal voting after the fact to decide which measures we would move forward as a process improvement. The data that we present, please go to the next slide. So the data presentation that we did included newborn delivery data, maternal delivery data. We had our Vermont Oxford data and our patient satisfaction from all areas. Move to the next slide. And the table discussions were focused on these 4 topics. So these were areas of opportunity. These were patients that, or these were the populations of patients that we were below the benchmark and needed to improve on. So hypertensive OB, readmissions, adverse outcomes, and our postpartum hemorrhage. So each table had that discussion, and they came up with their recommendations. Move to the next slide. So we developed each of the topics as they were presented led to some evidence-based practice ideas to kind of talk about and think about if Meritor might think about initiating. And then each table recommended 3 practice changes. And as I mentioned before, then those were forwarded to the bigger group, and there was the nominal voting to decide which ones would move forward. after those ideas were brought forward, then later they were taken to the steering committee and the nursery committees to further develop a quality improvement project or plan around making those improvements. Move to the next slide. So how do you hold a team accountable? That's probably the biggest challenge of all organizations, is you can see the data and you can tell people what to do, but how do you get people to keep doing it and hardwire practice changes? So first, the suggestions were brought forward, and in order to make things happen, I don't know if this is common at every other organization, but I'm guessing it is, that the easier you make it to have everybody comply, the easier it is to have everybody comply. So not only did we develop protocols, but we actually developed order sets that were, pre-checked and really made you do the right thing when it comes to orders and making sure whether it's a postpartum hemorrhage protocol or whatever is followed. Those types of things really help at Meritor, for example, to get things moving forward. We also, in order to make sure that everybody's still kind of following in the same direction, the subgroups that are working on individual projects or protocols then report back in to the steering committee with their progress. And then quarterly, the data is then reviewed on what improvements have been seen with the quality improvement work that's being done. And that's done at the steering committee. That's probably one of the most attended meetings. Everybody wants to see how much better we are doing. Move to the next slide. So now Lisa's going to lead us in a little bit of discussion about how you might implement or use some of these ideas at your own site.
Thank you. Yes, this is the part where we all get together. I did want to just sort of sum up by saying one of my favorite sayings is, so what? And what we mean with the so what of this is, for example, depending what your role is, I think it's important that we all understand how important data is and each part we play in it. So, of course, for data entry, doing the cleanest, most efficient job at putting it in is very important because people are relying on it to come back out clean. We all know that if you have garbage going in, you're going to get garbage out. If you have really good stuff going on in, you're going to get good stuff coming back out. So clean data entry is important, but then again, truing it up to verify with a variety of sources that your organization may have is very important. Pulling data out is, of course, critical, but it's not enough to just say my number was 20%. What does that mean unless you're looking at it within a larger context? And then ultimately, the whole reason we do this is to help use data to drive decision making, to allow us to improve quality efforts. You've seen we can use that very locally internally. We can use that at a community level. I think we'll be using some of this statewide and so on and so forth. So it's very important that we can take good information to help us make improvements. And as Kathy and also Bonnie mentioned, based on what you're seeing locally, you're going to do something that may be very different from something somebody's doing a couple hundred miles away from you based on what's showing up as an issue for you. So I think that's the summation, but we would like to either hear what is happening at your site or what ideas does this generate for you, or in general, if you'd like one of us to explain something in greater detail, we're happy to take questions at this time. So you can either type it in or raise your hand, I believe.
Yes, that's correct. If people have questions and you want to enter those in the question panel, please do so, and I'll read those as they come in. Or if you want to say something, you can raise your hand and I will unmute you.
Well, this is Lisa. Since I can't stand a vacuum, I have to say something. I was thinking of a couple of things, again, if they're not huge projects, but simpler things that we've done over the course of time. One of the quality things that we did do a couple of years ago is certainly ACOG has said for a long time now that all pregnant women should be tested for HIV each pregnancy. And of course, we had a number of people that, providers that perhaps didn't quite take that to heart so much. So we did begin running reports on, okay, which patients either did not have an HIV test done or we had an unknown on, and then if we did have that, were we able to notify the pediatric provider to see what they wanted to do about that. And I would say there was some pockets of people where it was up past 20% that weren't getting it done. Once we identified that and identified individuals, I would say we are down to almost never. In fact, the issues we have now are not so much that it's never ordered. We've run into a couple of computer glitches where something got ordered and the order fell off too quickly, so we're working at modifying that. But from a provider standpoint, we've basically fixed that problem, and now we're working on internal technology issues if and when they do arise. So that's another example. And I see there are some couple of questions here.
Yes, it looks like we have a couple questions. Lisa, if you want to read those off, you're welcome to do that. Or I can read them, and then you three can respond to them.
Okay, the first question is, does anyone use peridata.net reports for OPPE reporting for provider-specific data? And unfortunately, I'm having a TIA as to OPPE right now.
That's the data that you collect for credentialing to make sure that they have a quality practice.
Oh, okay. I can say that we do look for some of that within our organization, and we use this as one of the mechanisms, yes.
This is Bonnie, and every now and then I'll have an allied health member who's up for recredentialing, and I'll get a request for volume. So how many deliveries did I attend? How many C-sections did I assist at? So yes, I do use peridata for some credentialing purposes.
Excellent. Yeah. So again, the information in peridata.net may not be the thing that provides every single thing, but it certainly is an adjunct to many things that we're looking for. So it does look like a number of organizations use at least some of the information that's in there for those types of purposes. The next question is somewhat fortuitous in that I was just working on an email about it yesterday and today. The question is there consideration for peridata to be able to export data directly to Joint Commission, i.e. the breastfeeding measures? The data committee has had some discussions around what may or may not ever happen with that. Joint Commission has certain criteria with which they vet vendors for providing in data. I think they've changed their rules over time as far as whether they'll take that in or not. And we are probably going to revisit whether that would be something that peridata.net could ever be a vendor for. So that is a possibility. We are not doing it at this time. We do have in the system, however, even though Joint Commission just went to doing PC05, which was that not taking into account mom's choice, in the system we can still get at what was her choice and how does that affect things. So all those elements for that are in there now. And coming back to the first question about provider-specific data, there was another person on the phone whose hospital does use peridata for that kind of information for allied health as well as for their physicians. So that's good to see that others are using it that way too. Those are the questions that are up there now. Is there anything
It looks like,
else?
I'm sorry, Lisa, it looks like
Yes.
there's another question. Oh, no, you took care of that. But here's a question. For physician certification, there's a requirement now for quality improvement. Are any of you aware of any physicians who are using peridata.net for the quality improvement part of their maintenance of certification?
You guys have an answer for that one?
No, we don't at Meritor.
Not specifically individual providers asking for theirs. I can tell you, though, that the midwife population has asked me for a report that they submit annually to their organization, and I have to build that one, but it looks like I'm going to be using PDN for a midwife report that does show individual performance, but it's for a midwife reporting opportunity.
Also here, it's not so much for that type of thing, but in general, we do run reports for our residents. They're supposed to be entering something straight into their residency thing, but we have a report that our medical director also uses to verify accuracy both ways. So if somebody said they did, 10 C-sections and 50 vaginal deliveries and this many forceps or vacuum or whatever, we do go and check that with each rotation that comes through. So that's a slightly different way.
Yeah, we do that for the residents as far as validating for their accreditation as a medical school, and we also use it to pull data for research projects that kind of somewhat lead to quality improvement efforts. So if a resident leads a project and they need a patient list of patients with a particular problem, that at least they'll give them the first line or cut into the number of patients or types of patients that they need for their study, and then they'll do quality improvement from that.
That's actually a good point. That reminded me, I just got a request recently as we're looking at late preterm and temperature management. So I got a request for all preterms within the last 2 years, et cetera, et cetera. So you're right. Sometimes it isn't a specific data element that's in PDN, but we're providing a list of patients with certain parameters that the EMR is then used to look up that condition. So I think PDN is adjunctive to a lot of quality programs.
Yeah, and to Bonnie's point with some of that stuff, certainly you can get certain amounts of information off of coding and so forth, but not always. And especially if you're trying to look up something where there's something related between the mom and the baby. In fact, we just pulled a report for, again, it's for this Wisconsin Perinatal Quality Collaborative, and we were looking at women with hypertension and the number of kids going into the NICU, which, by the way, was a staggeringly high percentage. There's an association there for sure. But that's not something that you would get just off of looking at babies admitted to the NICU. You'd need the information on the maternal side in order to be able to help drive that. And it's very good for those kind of reports as well.
Here's another question, Lisa and panel. Are the data elements and definitions for the PC measures in peridata.net exactly the same as the Joint Commission measures?
I'd have to answer that. They're about as close as you can get. We do believe that it does measure the same thing, and I would invite anyone that if for some reason it looks like it's not, to please contact us, and then it'll go to the Perinatal Data Committee, because it is to match up the same way. And then it looks like, oh, I see.
Yeah, sorry, go ahead.
Oh, I see. Another question. I should be not talking because you got the questions there too, but it says, one person here is curious as to what level of personnel generally completes the peridata.net information. Is it nurses, unit clerks, quality? So there's a can of worms for you.
I can share what we what's done at Meritor.
Okay.
This has been an evolving process, but current state is initially the information is collected in the data sheets and then entered into PeriData by the Hawks. But we have a nurse that does the data abstraction for all of the questions. So it's only the demographic stuff that the Hawk initially puts in, then the nurse goes back and fills in all the questions, and then the rest of the information is sent through CIFRIS via the Hawk. So the Hawk then enters that into CIFRIS.
Yeah, and at our organization, the nursing staff, we break ours up into 3 sections. So a labor and delivery nurse, I actually took the PeriData worksheets, separated into 3 separate sections. So they're exact same questions, just broken onto 3 separate forms. Labor and delivery completes 1. Nurse 3 nurse completes the information related to the infant post-delivery. And then there's a postpartum section. So that's answered at the end of discharge. All 3 of those forms are then collected, put together, and clerk receptionist who does our data entry enters all of the information related to birth certificate and PeriData. If she runs into a problem that something's not filled out or doesn't make sense or can't read it, she needs to get verification from an RN in order to enter it. And then there is RNs, leadership especially, but clinical educators who pull the data, pull the reports back, and if we find that we don't have discrepancies, we'll go back and clean it before we do submission.
It looks like there are some follow-up comments to that. One person indicates they have one nurse with clinical assistant who takes care of everything. The clinical assistant does the birth worksheet, CIFRIS, and PeriData, and runs all the reports. Another person commented that the nurses documented into Centricity Perinatal, and then trained techs enter the data into CIFRIS and PeriData, and a designated RN always double checks the data. And then there was a follow-up question too. Are there any plans in the future to be able to populate PeriData with coded information versus just conditions? This commenter said that that's the piece that is most difficult in matching one-to-one with the Joint Commission measures.
Okay, a couple of comments on that. Number one of the things that the data committee and the vendor are working on this year is a way to be able to extract the EMR information and pull it straight into peridata.net. So that is something that we're looking at that should take a variety of fields and pull it on in. So to that end, it may make that more simple. Regarding the coding part of it, clearly as we're moving to ICD-10, we would want to make sure that we do some crosswalking and matching of that before we would put that in, but that may be a possibility. Flip side to that, however, which one of the people on the data committee reminds me about continually is, as I said, coding can be just as fraught with danger as other things. Granted, that's how Joint Commission measures currently are called out, because nationally that's what people have at their fingertips. But again, you will probably find if nothing else, PeriData at times can be a way to go back and check, hey, where am I having my discrepancy? Because as I've said before, I can find just as many coding errors, acts of omission or commission, as I can on the PeriData side. So we do have to take that and be careful with how we're doing it. So it pays to have some kind of truing up done prior to using whichever system is gospel.
And we did get a comment that coding also presents significant time delays.
Correct. Another thing to keep in mind is some of the information, though, that you're doing on the PeriData side does allow you the ability to get as close to real time as you possibly can. You know, it's things that are happening kind of right then and there, and depending on when coding and billing goes out, that can be considerably later. Okay, and then there is another question here. There was a discussion about connecting directly to an interface for various vendors. I believe what they're working on is, I'm not very good at communicating this because I am definitely not a tech person, but the idea is having a consistent language that allows things to be pulled from the EMR to the PeriData side. So whatever that language is, if the facility can line up and crosswalk which field goes with which, I do believe it would be possible to bring that over. But don't completely quote me on that because, again, I'm not a technical person, but I'm pretty sure that's what the vendor is talking about doing. So right now I'm not seeing any further questions. Again, this will probably be last call if you do have any. And again, I'm hoping that this session at least has given you a little bit of an idea of the number of possibilities for using the data that comes out of the system. Yes, it's important to get information in, but the reason that we do that is, again, to be able to get it out and to use it to improve the care that we provide to the families that we're serving.
Okay, I was just scrolling through and it looked like somebody had a hand up, but I don't see that now. And I don't see any other questions right now. As we said at the beginning, if you do have questions that weren't answered or other things that you think about after the conclusion of this presentation, please feel free to email them to WAPC, and we will do our best to try to answer those for you. Let's see. If you have questions for any of the presenters, here's their contact information. The slides for this presentation will be made available to you after the conclusion of the webinar. And please note that the next one will be July 22nd from 10 o'clock to 11 o'clock. If you have any questions about that, please contact WAPC. Do any of you have any final any comments before we close?
Again, I think, as I just had mentioned before, just again, the importance of using data to drive quality decisions that you're making either in your organization, in your community, across the state. Those are all important things. And so we thank you for anything you can do to help facilitate that. And thank you so much for your attention today.
Okay, and thank all of you for presenting, and thank you, the participants, for attending this session. Have a good afternoon, and we will see you later.